It's my honor to introduce Dr. Danielle Tate, who is our outgoing maternal medical director for TIPQC, but I know all of you know her well, as well as a local Memphisite, if that's the right way to say it. So,
Memphian.
Memphian. Okay, so here's our Memphian. So we appreciate your willingness to share with us today, and I will turn over to Dr. Tate. And before I do that, my name is Brenda Barker, and I'm with TIPQC. I should have introduced myself. And we recently found out that our maternal mortality, our numbers have increased. We're now number 47 in the United States. And I really believe a lot of this work around cardiac will save lives. So I really appreciate you coming. And again, any way we can help spread that message with the magnets, with all the training that we're giving, the free resources, please take those and know that our mission, our goal, our hope is that these save lives. So now I'm going to turn it over to Dr. Tate.
Thank you. Good morning. Good afternoon, everyone. I know maybe watching from other time zones. I'm going to go ahead and get started. We will have time for questions, but feel free to interrupt if you have a question. We're first going to start off with just kind of overview of what we are as TIPQC, and then reviewing our statewide statistics as it relates to maternal mortality specifically. We're going to talk about how to identify and screen for cardiac concern for pregnancy, or I should say the perinatal period. So that includes postpartum as well. And we're talking potentially up to a year after a patient delivers. Management of hypertension, as it ties in definitely very intimately with cardiac disease. We're going to talk about referring patients in this perinatal period for treatment or evaluation when they have been identified as someone who potentially has or reports a history or is currently having a cardiac condition occurring. And then, of course, questions and answers. So we start with TIPQC. We are the State Perinatal Quality Collaborative. So what does that mean? We are the group of healthcare professionals that are tied in closely with the care of women or people, pregnant people, and those that are newly postpartum up to a year. And what the goal of this collaborative is to, of course, keep people healthy in the state of Tennessee. So reducing morbidity and mortality. We collaborate with many other resources, including our state leaders, Department of Health being one, other entities such as the Mother's Milk Bank, as well as our outside resources like doula organizations, with our providers, CMOs. So TennCare is a big partner for us as well. We've been in the work since 2008, so 16 years of work here that we've been doing, over 30 projects. Many of you have joined a project, you've probably heard of it. They cross both maternal and infant sides, as well as we have some collaborative projects that we've been doing for the last few years. And those are just a few of the other things that we do in relationship to education. So we do have coaching through QI work if you're doing that in your institution. We have our annual meeting, learning sessions, webinars. We're going to find you if you have ears. We're going to find you to teach you something. And those are the many ways you can do it. And I would encourage everyone to visit our website, and you can find out all that information. That's kind of our main hub of everything that we've done, that we're doing, how to contact us, or all of our partners that I'll mention at the end of this talk. Currently, we have 42 hospitals having participated or currently participating in the TIPQC project. They do roll for about 2 years at a time and then go into sustainment where the work is continuing, but it's not active as a statewide collaborative. You can see we're all across the state as far as partnerships with hospital systems, including West Tennessee. And we actually have partnered with pretty much all the hospital systems here in the Shelby County, Memphis area, and have done great work with them. Regional 1 being really one of our hospitals on the forefront because they are a perinatal referral center. And with that, we are impacting 82% of the births that occur in the state. So when we look at maternal mortality in the United States, we've heard that it's not doing well. We are probably copying definitely all of our first world countries, and we are getting numbers at or above third world countries when we talk about maternal morbidity and mortality. And you can see as we break it down based on race, it is rising in all races as identified, but especially our non-Hispanic Black patients are always topping the list at times being 2 to 3 times more likely to die in pregnancy than their counterparts. When we look overall at mortality, this is the most recent data in the United States as of 2021. We can see compared to 2018, which is not that far in the past from 2021, the numbers have pretty much essentially doubled as to what we're seeing as far as maternal mortality. You can probably guess, right? The obvious thing here was COVID and the impact of it, whether it was the actual infection or the lack of seeking care while the pandemic was going on. You just wanted to stay safe, but it didn't work out as well for pregnant persons. So we're going to dive a little bit deeper and talk about statistics in our state, right? You're really relevant to us. And I know we have a varied state and how we look on different sides and different areas, but when you look overall at state statistics, our data as well is as recent as 2021. We actually just wrapped up the 2022 review, so that data should be coming out in the next few months. But we rank 4th in the nation in maternal mortality, similar to what Brenda just mentioned. We're seeing the same. Non-Hispanic Black women are 2.5 times more likely to die in pregnancy or during the peripartum period, and that could include postpartum. About 89% of these deaths that we see are actually deemed preventable in some way. And it's a lot of layers there. It's not just one finger to point, but we do recognize that they are preventable. And what we're seeing is we're following pretty much the top reasons you see across the nation, with cardiovascular disease and coronary artery disease topping the list of why women die in pregnancy in the state, along with hemorrhage, mental health. We can also add hypertensive disorders to that and VTE or blood clots.
Right. Yeah.
Our state data looks a lot like the national data, right? And then we had a big jump when you go from about 2018 up to 2021, where it looks like it's more about a almost 3-time triple increase. And again, it lays more on the same things we just talked about on the slide. And so here we go, we have something to work with, knowing where we have work to do, and we want to be thoughtful in how we address it. So when we break down the reasons why between 2017 and 2021, persons died in the realm of pregnancy in the postpartum period, cardiovascular disease tops the list, and even triples some of the other reasons you see. And I think it's astonishing, right? Because we assume our patients are young and healthy, and they shouldn't have problems with their heart. We can understand hemorrhage. We can even understand hypertensive disorders and preeclampsia by themselves. But when you put together that,
I'm sorry.
They can't see the Zoom on Zoom. They're not seeing the PowerPoint. They were, but now she's going to try to make sure our Zoom folks can see it. But you can keep going if you want.
Sure.
Thank you.
So you can see how that tops the list with cardiovascular disease. But we still are seeing things that you would expect. COVID-19 is in the top 3, hemorrhage as well, top 2. Substance use disorder is very much more significant than we think when it comes to relatability to pregnancy mortality.
Can I ask you a quick question before you go on? Somebody mentioned to us in a different MFM lecture lately that risk of death from homicide is actually higher than any of those combined. Is that true?
It is, but it's not technically pregnancy related.
Yeah.
So understand when we do, and all the states do the same, when they do mortality review, homicide, suicide is pulled out and reported separately. So you're absolutely right.
Okay. I've seen these stats so many times, but that totally threw me off.
Yeah, and it's something right in the bigger talk of things, because we do have to be screening for intimate partner violence. We have to be screening for guns in the home. You know, definitely mental health plays into that as well. So it is part of the bigger bite of tackling this issue. Absolutely.
And did we see any change like after we controlled the COVID? Because your data is from up to 2021, right? When COVID was like now 22, 23, 24. Are we seeing the same?
Same trends. Yeah, and now the question comes up, are there long-lasting effects of COVID
On the
that
cardiac?
could potentially have affected someone's health going into pregnancy or even during the pregnancy? That data is going to take, some time to come really understand the numbers, but yeah, absolutely. Even with taking out, we're still seeing the same things. No, it wasn't serious. I can find it really quick. Turn like slide 10.
Yes.
Right. Thank you. Okay.
Hold on, it's not advancing now.
I think I got it.
Oh, they're good, okay.
Perfect. So when we look at the breakdown of when this is occurring, right, which is a very important conversation for today, we would all assume surely it's happening when they're pregnant, but the majority of patients are in the remote, what we would consider remote timing, right? Most of them have transitioned out of pregnancy care with their OBGYN. They're back hopefully with the primary care, and guess where they're showing up? Not in triage. Not at the OB's office with a complaint. We're seeing more and more, this is your emergency room visit, this is your primary care doctor visit, this is someone outside of the realm of obstetrics. And a lot of what we see has to do with just it's not necessarily that you don't realize it, but you don't realize you have to connect it with pregnancy. And most times we're forgetting to even screen to see if they've been pregnant recently, which may change the course of the entire evaluation and treatment. About 4 in 5 women in our state all have pregnancy-related deaths, meaning that these deaths were related to pregnancy, whether pregnancy actually sped it up or caused it, right? Or it wouldn't have happened if they had not been pregnant or pregnant recently, and they were all deemed to be preventable, right? That's a staggering number. We're all working really hard, and one's pointing a finger about anything, but we felt as a team, probably time to just kind of acknowledge it, make sure everyone's aware of it. Awareness is really big, and then educate on how pregnancy crosses a lot of things that typically not pregnancy, right? 2 in 5 preventable pregnancies were determined to have a good chance of actually preventing it. So it wasn't some, maybe, could be. It was a little under half could have had a really good chance had the course been different for the person. When we look at contributing factors in our state, and that's specific to the last set of data we have in 2021, we noticed that provider delay in treatment, especially for things like preeclampsia and cardiac disease, were a significant contributing factor. And it may be just delays in recognition or delays in initiating proper treatment, or even delays in ability to get a patient to be seen, right? All of those things impacted us, especially during COVID times, where we're trying to keep people as safe as possible. In the realm of cardiomyopathy, patient's history of substance use disorder, right? That is definitely something that's relevant inside and outside of pregnancy. If she had multiple pregnancies and really no documentation of contraception counseling, especially in the setting of having a diagnosis that really needed to resolve or be optimized before the pregnancy, and not adhering to medication regimens. We all know and can imagine what it's like having a new baby at home, and sometimes it's hard to keep up with self, right? You're focused on the new baby or the pregnancy. And then the multiple comorbidities. And I think we know especially the west side of the state, there's a lot of overlapping of younger patients being sicker, right? With more chronic illness and still fertile. My family is still fertile. So when we talk about this in the realm of TIP-QC, here's where we enter the conversation of how we can help in the vein of quality improvement with this matter, right? So our aim with this project that we'll be rolling out soon in the next month or so, it's called Cardiac Conditions in Obstetric Care, but what we're really trying to do is decrease, right? Deaths related to cardiac disease. Now, it can be a very big bite. Some of you may be hesitating saying, I can do it all, but I'm not a cardiologist. I don't have a cath lab or whatever we need. But really it's about improving care through screening and recognition, and then funneling patients into the proper channels to make sure that we save lives, that we make health better, that we prevent morbidity and mortality, right? And really our goal is statewide, increasing the screening and referrals to at least 90% of those birthing people who are pregnant, and hopefully reducing the preterm rates of delivery related to cardiac conditions by 10%. And that is our goal for June 2026. Right? That's plenty of time to save the world. So what does that mean? I think we can all, online and in the room, think back to a patient that we've probably seen either with a cardiac history or in our presence developing or had developed one. And what does that look like when it relates to pregnancy? So we'll first talk about cardiovascular physiology. I don't think we give enough credit to how the body changes to adapt to a pregnancy. And the cardiovascular system is probably one of the top ones that goes through the most drastic change to accommodate this growing body. And when you think about it, this heart is working for two. And one is really needy and very demanding and growing fast, right? So what does that look like? What we know is there's an increase in blood volume, 30 to 50%. And guess where most of that volume is going? Through the heart and to the uterus, through the heart and to the uterus, right? And it's accommodating baby, but it has to move things to the uterus to make sure baby's able to stay healthy and grow. Therefore, your cardiac output increases. And this can begin as early as 7 weeks of pregnancy. And it usually peaks between about 5 or 6 months, 20 to 24 weeks. That's not far along in the pregnancy, right? If something were to happen, and most times we're thinking, oh, she's just kind of still adapting to pregnancy, but this can be felt. And imagine if someone comes into pregnancy already with a deficit of some sort when it comes to their cardiac history. Heart rate goes up naturally. Most people don't feel it, but if they're already at a high heart rate, they may feel this increase. SVR does decrease by 30%, right? Everything's relaxing to accommodate the extra volume that's seen. We know that pregnancy is a hypercoagulable state that has to do with how the womb is growing and pressing on things. It also has to do with clotting factors and how they're produced. And so in general, everyone in pregnancy is at risk, but you don't see it as much as you would think, because most patients are still active and moving. However, when you enter changes in their cardiac condition starting early in pregnancy, it does put them at even more risk. And then we see fluctuations in volume, especially during labor and delivery, because now they've delivered and everything starts to shift back to normal really quickly. And so the heart, if not the strongest, can quickly become overwhelmed during that time as the body's trying to get back to quote unquote normal. And this is what it looks like. Pretty much all of your cardiac measures are going to be increased in some way or change significantly throughout. And it peaks around the third trimester. Peaks around the third trimester. And that's usually when the baby's growing the fastest, right? As you enter 28 weeks or so, babies are going to be picking up weight weekly, significantly. And with that, there's more to accommodate, more to support alongside. Blood pressure is interesting. It actually gets better. It falls the majority of pregnancy. We see where it hits its nadir or lowest in the second trimester, typically around 6 months or 24 weeks. And then it slowly rises back to look like it did prior to pregnancy or at the start in the third trimester. And I love to bring this up because most of our patients aren't going to enter into pregnancy until the change is already started. So sometimes we will miss a diagnosis of chronic hypertension because we just haven't seen the patient early enough. And then too, it helps us understand preeclampsia more if you understand what you're supposed to see. If she is 20 weeks and spiking severe range pressures, that's not normally she's supposed to be lower than what she's expected to see. But an interesting change, and it has to do again with the combinations of vitamins. Positioning can influence this. So if you have someone flat on their back, if they're laying on their side, that may make the blood pressure look higher or lower than what it's supposed to do. And typically lying on the back, on the side is going to improve things. So I love it when a nurse says, well, pressure's fine when she's laying down. I said, all of our pressures are fine when we're laying down, but we can't live life laying down. So just remember to repeat and adjust sitting, standing, just to make sure you're getting appropriate measurements. When you have pre-existing chronic hypertension, just as I mentioned, you will see lowering, and they will have a greater drop in their blood pressure throughout the pregnancy. And this is what it looks like and what you expect to see that you start coming into pregnancy around where you started prior to, and then we dip and we come back up to pretty much measure what we saw at the beginning of pregnancy. One factor too to put into here is blood pressure medication changes, and we'll get to that in a minute. If she's been on really great, strong antihypertensives that now we can't use in pregnancy because they cause birth defects, you have to acknowledge the change may not be equivalent and that she may need more of what is safe to continue to keep or maintain. Final common pathway, right, we see with cardiac disease typically is pulmonary edema related or arrhythmia related when we're talking about acute onset of cardiac conditions in pregnancy. EKG changes that you should expect to see, these are the normal ones. The mean QRS axis shift to the left. You can see minor ST wave changes, small Q wave, T wave changes, and you may see SVT or extrasystoles are really common. Most times patients don't feel this, but if they do, you can easily treat with a small beta blocker dose as needed. Those are what we expect. Anything else, I would definitely dive into making sure you understand what's going on. When we talk about X-ray changes in pregnancy, you usually see prominence of the pulmonary vasculature, flattening of the left heart border, right? And that makes sense because it's working more and you have changes from the uterus pushing up. You can see the diaphragm elevated, definitely caused by the uterus growing and the baby pushing up on everything. And then the cardiac silhouette may appear more horizontal. So those are what we expect to see. Anything else, again, is not expected in pregnancy. And so what this looks like is what we easily can assess through point of care ultrasound. And I know that happens a lot in the emergency room. You should be able to assess a lot of what we've discussed on ultrasound as whether it's what we expect to see. And then you may have to go to higher level ultrasound views of the heart if you expect more. As far as the echocardiogram goes, we expect to see an increase in left ventricular shortening, and that has to do with the work of the heart. You may see small pericardial effusions. They're not uncommon because third spacing is common in pregnancy. The majority of the time we'll see third spacing right in the legs. Everyone's swollen in their ankles and feet and calves, but you can have small spacing of fluid in certain areas otherwise. And then we do see increased incidence of mitral regurgitation. Again, that's a normal change. Anything else? We talk about BNP. This is a fan favorite to order if you're expecting a change, right? And it should be ordered because it should not change significantly overall during the pregnancy. Now, the factors that go into it will adjust for pregnancy, but at the end of the day, the BNP does not change significantly just because of pregnancy. Ultimately, what happens, it does increase some, and that causes basically increasing in diuresis and letting out of fluid, which makes sense because they can become volume over, right? They're already carrying more volume to start. Remember that pregnancy, as I just mentioned, is a physiologic volume overload state to accommodate for baby, and your left ventricular wall mass and diastolic dimensions do increase as well, hence ties into the BNP. And you'll see naturally does go up. Now, this is one study, they looked at 72 healthy women and noticed that BNP levels are expected to go up to accommodate pregnancy, and then they come back down pretty much to the baseline in the postpartum period. But there was no difference in this number. So even though it goes up, it's not a statistically significant number that you should expect. So anything more you should expect is related to a change to the heart. When we talk about heart failure in women that are pregnant, dilated CMP, higher BNP predicts adverse cardiovascular outcomes. So they are. My only rule is order what you know how to interpret. So if you're not a BNP expert, don't call me, I'm a cardiologist and ask them what it means. Asymptomatic left ventricular function is useful to evaluate shortness of breath. Now, every pregnant woman is going to be a little short of breath. Everything's pushing up. She can't get good deep breaths in otherwise. And so with that, don't just blow it off, but evaluate it more. And usually a lot of it, you can just start with their history. They're saying, oh, I only get short of breath when I walk up a flight of stairs or I take on Walmart for the full day. That's fine. But if she's short of breath, rest, wake up short of breath, those things need to be evaluated where they could be reactive. Yes.
I have a question. So, are they kind of equivalent to CHF patients? Oh, okay.
And most times that's when we say pericardial cardiomyopathy, that is the pregnancy version of heart failure. And that's one of the top two between that and seeing arrhythmias.
So you can get like an actual heart failure of pregnancy, and it can happen during pregnancy, but more often postpartum.
Absolutely. And the biggest time is just as Dr. Bradley mentioned, is postpartum and then the last month and a half or so of pregnancy, which can get really confusing because every pregnant person in the last month and a half is huffing and puffing around. They're short of breath, they're tired. So it just may take a few more thoughtful questions and workup to make sure it's nothing idiopathic, especially going back, or not idiopathic, but nothing more serious, especially going back to the fact that we know in our state we have baseline sicker patients with more risk factors and chronic illness that could trigger this. So identification and screening of women as it relates to cardiac disease and pregnancy. We go back to the CMQCC, and that is the California Perinatal Quality Collaborative. They set the gold standard for this work because they've done it successfully and they helped us understand where we should be looking. And we start first with contributing factors as to why this would be a big deal. The first is healthcare provider related. Again, we're not pointing fingers. But again, I really think a lot of it goes into the fact that we're not expecting this in our patient population. These are young, healthy people with no problems, right? But about 69% of the cases that they saw were due to healthcare provider factor. And that could have been delayed response or inadequate workup, could be misdiagnosis, thinking something is not, or just failure to get a higher level of care for the patient when you did identify something similar. In the realm of quality improvement opportunities in that area, that's where we talk about making sure we're all educated on recognizing the signs and symptoms of cardiovascular disease in pregnancy and not just attributing it all to being pregnant, right? And some of the biggest ones are confusing. Shortness of breath and fatigue, I already mentioned. The tachycardia and the blood pressure changes, we talked about that. Low O2 sats can be something that changes, especially with activity for a pregnant woman. And then making sure we are addressing factors that could trigger this. And hypertension in pregnancy is a big one. When we look at patient-related factors, there's the underlying medical diseases popping up again. Obesity is a big factor, and that's something that we deal with as a state. Delaying or in seeking care, right? We see patients all the time where we're kind of frustrated, like, why didn't you come in earlier? And there's, reasons that are valid. And then lack of recognition for the patient to understand what a cardiovascular symptom is and seek help. So the opportunities there, of course, are patient education, especially educating on when to seek care, right? And telling them they're never bothered to call or come in. And then support. Are we helping the communities be more supportive so those risk factors go away, right? And there's a lot of things we could talk about, a whole nother talk about what those look like. But that's how we can hit it from multi-level areas. What we do know from the California Collaborative is that 24% of all cardiovascular related pregnancy deaths were potentially preventable. We're seeing those same types of statistics in Tennessee, right? And we already talked about the factors and how we could all do our part in making sure they are not there, right? So in conclusion, what they found was that signs and symptoms of normal postpartum pregnancy changes can mimic cardiac disease and vice versa and can be misinterpreted. So you just want to make sure you have a plan in place, which we're going to talk about examples of that so that you don't miss the diagnosis. Wasn't diagnosed the majority of the time they saw it, wasn't diagnosed in pregnancy or wasn't diagnosed until after the person gave birth or died, unfortunately, and they realized what actually caused the death. And then just increased awareness, especially having suspicious and working that up, were potential impactful on preventing the outcomes of this cardiac disease, even though like, a lot of times you can't prevent it from happening, you can definitely prevent the unwanted outcomes of it. And then including in that preconception counseling, right? Which, we're working on the OB side of how circling back and talking to patients after they deliver, after they went through the big event and really helping them understand what happened. And then talking about pregnancy timing, health in general, long-term care. We have things in place now like extending healthcare access via insurance coverage for a year. So that's helpful, but we can understand as the worker bees, the next layer is, do we have the resource? Now they have insurance, where can we send them, right? So we're working on that with the state entities as well. So here are the most important questions to ask. Are you pregnant? That's a real simple one. That gets missed a lot. I'm telling you, it gets missed. Have you recently been pregnant? right? And not a Memphis minute, everyone knows what that is. It could be, right? But how long ago was that? Because we want to know about the last 12 months of her life, really, if she's seeking care in a non-pregnant state especially, or could be very early pregnant. And so here are some things, and the next few slides are going to be some examples of how you can have these things posted in your units. You can share information with your colleagues as they take care of people who can be pregnant, right? Guess what? Anyone can be pregnant. And a lot of times I'll get calls, and that's the one thing that wasn't done, a pregnancy test of everything, right? But looking at this, we bring in the physical exam, vital sign changes, symptoms that the patient may report, but isn't this a great way to trigger you to what to ask in case they don't report it freely? And then looking at risk factors that could be present for the patient that could lead to cardiac disease. And on there, 40 years and over, I'm seeing more and more women who are what we would consider delaying pregnancy until their 40s, right? Or late 30s even. My last patient, oldest, was 50. She just delivered a couple of weeks ago, did great, right? So it's a real reality thing. I think definitely in our state, BMI is gonna come into the conversation, diabetes, hypertension. And then, we talk about illicit use of substances, but what about the ones that are not illicit, nicotine and alcohol, which can play a big role into their health, right? Make sure we're screening for that. And so with that, this brings you down to, well, I've identified a patient at risk. Here are the labs and the imaging studies I should be doing. And if those are abnormal, that pushes us towards a referral pathway to get the patient into appropriate care if that's not us, right? But within all of that, it's going to be really important to counsel patients about what's going on, because we want them to take it as serious as we are taking it. And especially in the setting of acute care, like an emergency room, we know that that time is finite and you got to push it on to the next provider with the patient's help. This is another more simplified way to do that screening algorithm. So we have our red flags that would trigger prompt evaluation. And maybe there's no red flags, but she reports a history. We still need to push her to a specialist that can continue care. And if she's pregnant, that usually is a combination of maternal fetal medicine and cardiology working together to make sure that chronic condition doesn't worsen during pregnancy and affect the pregnancy or vice versa. Again, another algorithm. We put variety in here because everybody likes to do it different. So hopefully one of these will trigger something that will fit best your personal practice or your unit practice so that everyone's aware. These things can be printed and put throughout the unit, next to computers, on your wall of knowledge, or even smaller for badge buddies so that workers can easily get to it and know what to do. But another algorithm, right? It involves, again, looking for risk factors, symptoms, vital signs, looking for a combination. And I like this one because it tells you if you have this many, this is where you need to go. If you have this many, this is where you need to go. And then knowing what to do when you have abnormal versus normal results. And Brenda's holding that up in the back. So we have some copies if you guys want to take as many as you can or want to, you can give them out. They're badge buddies. They're kind of big, but I was told they were good because they would stick out behind all your other badge buddies. God bless the nurses. You guys gonna be like Hunchback of Notre Dame without the badge buddies. They all have. But we appreciate it because we never know if the doctors are like, what's the answer? So I get it. This is actually an example from UT Knoxville, and they have it built into their EMR as part of the assessment sheet, which I like in the evaluation, and it's a hard stop. You can't close this out without answering these two simple questions. Are you pregnant, or have you been recently pregnant? And were you told you had high blood pressure while you were pregnant or right after, right? And I think that is a great kickoff point. And it's really simple. And I love a good hard stop. I get frustrated, but I'll answer it so I can go on to the next thing. This is actually from St. Thomas Midtown. They have it built in. Epic is their system, and they have an entire detailed question, yes or no question assessment for cardiac disease for their patients around pregnancy, right? And it really goes into more of asking the questions in a way to get the response needed regarding how they're feeling. A lot of it is symptom-based, and then it goes to asking about the vitals, and then what it eventually will do is do a calculation and tell you the risk. Yes.
So this is the triage nurses asking these questions or the
Yes.
physicians asking?
This, from what I understand, is the triage
Triage,
nurse.
right?
Mhm. Same here.
Mhm.
Now, I know it can be, there's a lot of questions I get. You may not want to put that many, but we put this in here intentionally to say this can be built into what we use every day, which is the medical record system, and not have to worry about separate assessment. But if you have to do hard copies, we have these as well. And this is a version of an assessment that you can have in your unit and pull out when you identify a patient who's at risk. And it allows you, again, to point system out history, symptoms, and then total them up along with a guide on what the score is and where to go and the next steps, right? And then knowing what to do or what the plan is. Now, this one may be a little bit tricky, right? Because paper anywhere in the hospital can get lost. And then you got to make it to the patient's chart, to the scanner. I get it. But maybe taking something like this and interpret it into your EMR so that you have it all together would be great.
Are they screening everybody who comes in and says they're pregnant or has been pregnant last year?
So that's the question everyone should get. That is biologically female.
Yes.
And then based on the symptoms or the presenting complaints. Right, yeah, you don't have to do it on every single patient, but it would be something to help you once a suspicion is triggered.
Okay.
I
So
get
like,
what
feel like you know you're telling me like you don't have to.
No.
Okay.
No, unless you feel on your chest after you stub your toe in, no, you have chest pain, so.
No, I think I do think. I think Dr. Graves said she has a box of those paper ones in her office and they do screen every. That's in her.
Okay, it's a little different.
It's a little different than MFM, we're looking for stuff.
Yeah.
And we usually find it.
Yeah.
But the OB office, triage, ED, I know what you guys are thinking, like, no, not happening. Too much to do. But at least having this resource available, making sure everyone is at least educated on it, whether it's in the EMR or on paper to help guide. This is also, we have these copies from ACOG. You can take as many as you would like. Another way, again, to do a checklist. This is a little bit more simple, right? But understanding that you're gonna aspire for it. What's our plan for her current situation, especially if she's pregnant? We need to move her to a higher level of care. If she's really sick, where she can get to MFM cardiology, or do we have it here? We just need to call them, right? And then where she needs to go. And then making sure we are documenting communication, especially the point person, right? And I know it's idealistic to have one person to do all this work for us, but we know realistically it's not gonna happen. But having maybe some champions in this area to make sure the movement's happening for the patient. That's our badge buddies again. We love that. Look, it has our QR codes, like case. Okay, if you can't remember, you go to our website and learn about it, right? But I love a good moment of, I'm a visual learner, so this helps me in the visual, memory person. That can put all these things together in one thing, so you don't have to always searching for the information to help. I want to take a pause. I know we're talking about cardiovascular disease, but I definitely want to touch on hypertension in pregnancy, because again, this is your number one link usually to a cardiovascular event, is that there is cardiovascular disease that either goes undiagnosed or because it's there and the impact on it, we quickly lead to a cardiovascular issue. Now, these are more, we have these on our website. They are part of our hypertension in pregnancy project that we just closed out, I believe, last year. Officially, Regional 1 did take part of that, including, and as well, Methodist Germantown and Baptist Women's were all part of that project, Methodist South as well. So we were all, as a community here in Shelby County, working on hypertension in pregnancy. But again, this basically goes through the same algorithm of, are you pregnant? What are your symptoms? Ooh, your blood pressures are up, let's get some labs, and then kind of tells you how to tier out what you find when it comes to the symptoms, the blood pressure, and the lab work. And identifying, is this hypertension in pregnancy, and then what is the level of that? And it's really interesting, hypertension in pregnancy I look at as spectrum. You got the mild over here, and then you got the really bad over here. And every patient's different as to where she will enter into hypertension in pregnancy and where it will go from there, depending on the plan for the pregnancy especially. So I never, ever take light hypertension in pregnancy. In my opinion, it's super disrespectful. because it does not like to show up the same time every time, and it just randomly picks people and who it's gonna affect. Even with risk factors, you can have the healthiest patient end up in a situation that is dire related to this. We are very limited in pregnancy on what we can treat for high blood pressure. Here are our top three. Labetalol, hydralazine, nifedipine. Those are the safest. Those are the tried and true. We have our limitations. This is a great table to have if you are seeing a lot of pregnant women, right? We have them in our triages, our offices as OBGYNs, but that's where we're limited. There's probably one or two more. We don't use their older medications, but anything else we can't use unless it is life-saving, and that's the only thing I can give her. And we'll just have to take the risk with the pregnancy. But these are definitely well tolerated by patients. We have immediate versions of all of these. So if you got it, she's in a hypertension emergency, urgency situation, and we need to get it down, we can do it. Typically with IV for these two, procardia or nifedipine immediate release 10 can work just as fast as IV labetalol or hydralazine. So what I typically would recommend, I think we all would, Dr. Brackney as well, is that you stock these, because these are really comfortable for your nursing staff to give while they're waiting on the doctor to call back. We may not feel as comfortable with pushing IV medication without notifying a doctor or doctor presence. But these all work well. They have their side effects, but they're not anything detrimental to the pregnancy.
I know we have a nurse-driven protocol here. Do the other hospitals
In the area do, Baptist Women's do, yeah, they both do. They've adapted some version and they actually include nifedipine. So if you're not in the triage area or labor and delivery and you call over, that's probably the order they're gonna give you. Say, go ahead and give her 10 to procardia, we'll be over, or we'll let the doctor know. But yes, there is a version and all things are working towards allowing nursing staff to initiate this while you're waiting to contact the physician, which I know sometimes we're tied up and you don't have the time to wait, because we don't want to get into a stroke, heart attack, brain bleed situation because there's that delay.
Can you speak to the risk, why pregnant women are so much more vulnerable to lower blood pressures even than like the 80-year-old man who comes in with a 160 over 110 blood pressure?
Meaning to go high and low.
Yeah.
Yeah, it's the hypoperfusion effect of everything. And we talked about volume changes. And so, yeah, you're not going for completely normal in most of these patients. You just want to get them out of danger zone, right? So we're talking 160, 180 systolic. We need to just get down to 140s and keep going, because we don't want to hypoperfuse areas in the body. And that can happen. And I've seen it happen very quickly with over medicating while you're trying to do the best, but give the medications time to work.
Yeah, I think like the thing that's different about the way we treat pregnant patients is that we treat them very quickly, probably faster than most other specialists and specialties do. Our goal is to get their medicine within 15 minutes of the door. They've got a severe range blood pressure. So systolic over 160, diastolic over 110. So we treat aggressively and repeatedly, very quickly, but we also try not to drop them too low. So it's like a very narrow, quick window that we're shooting for, which is, I just know it's different than the ICU, it's different than the ED.
It's specified that it's 160 or greater than 110 instead of the combination, because I think that gets lost.
It's right here on this algorithm. One or the other, and for our colleagues here who don't work in labor and delivery, typically with pregnant women, these may not be blood pressure levels that are alarming, right? You may be more in the, it's 250 now, we gotta treat. But for us, we also would treat aggressively at more high levels, if that makes sense. So there is more likely chance to get into a hypotensive state, right? And you gotta realize, right, the brain auto-regulates. So at some point, you gotta recognize if it's been going on longer than we think, her body has adapted to a certain level of this, so we definitely don't want to drop too low, and the brain can't process and accommodate this new change that's happening so fast. But this is another algorithm you can use specifically on how to use our top 3 meds when you identify an issue and it needs to be treated quickly. And just like Dr. Brackney said, once you start giving meds, we're giving rapid repeats, right? 10 minutes, 20 minutes, we may be assessing and giving even more medication. And we recognize sometimes there can be stacking, so you have to be very thoughtful. And you'll see, and I think it's on the page, that as we give more, we give more. So you may start with 10 of procardia, the next time you're giving 20 of procardia, right? You're starting with 20 of labetalol, and the next time we're giving 40. So we're stacking in several ways. We want to be thoughtful. Now, this algorithm and the next few slides are actually from ACOG. So these are great if you don't have any other resource other than TIPQC. You can go to our website. You can use these. These are great places to start and finish. They're actually what most you'll see labor and deliveries and triage areas use. They just haven't forced a change in the wheel that's already working.
I have a question.
Sure.
On those three medications, are there any kind of like, are those like basically the go-to like universal medications, like those, there is no like allergy or anything like a latex or any kind of?
Well, if you had a patient that couldn't have, you could do alternatives, but no, these are probably the only three you're gonna have for any emergency situation. Now, of course, if you have to give clonidine, that's safe. If you have to give, I'm trying to think of other ones that you give, and sorry, somebody said.
Directly like Ardent.
Cardizem,
We do.
yeah, Cardizem, we can do those. But when we move into those situations, we're talking delivery as well. Because at that point, she's so sick, we need to get the pregnancy out of the way so she can be managed appropriately with whatever we need to use. But there are times when you'll have adverse effects, side effects, and patients don't want to take. For instance, nifedipine is notorious for causing headaches in a lot of patients. And guess what's one of your biggest signs of preeclampsia? Headaches. So you have to tease that out. And I've had patients who get flushing from beta blockers. They get sick to their stomach with the nifedipine, and we can alter, right? But most times what we end up having to do, unless it's a life-threatening allergy or adverse effect, we try to treat that with the medication given. So I do a lot of times I will give headache medication with nifedipine if that's the best or the only thing we have, right? Maybe she doesn't have IV access quite yet and you're trying to get it and that's the only thing we can give. So there are ways we get around it. I'm sorry, I have 5 minutes. I'm gonna speed up. I like to talk. This is all great news. Listen, we can do a whole series of TED Talks on hypertension, right? I can get you a full workday out of hypertension if you let me talk long. But those same algorithms that we mentioned exist for hydralazine as well as labetalol. Again, you can get all this on our website if you wanted to find it printed or ACOG as well. This is a great checklist for postpartum preeclampsia. And this may be something we want to have in all our units where it's a touch point for a patient who recently delivered. You know, most triages won't see patients beyond 6 weeks postpartum. So now we enter in the emergency room, the urgent care area, maybe even the ICU if they're really sick and no one forgot to realize she just had a baby, right? This is a great checklist. Interesting, very quickly with postpartum preeclampsia, guess what? It's just like preeclampsia when they're pregnant, there's just no baby. And it's the most confusing thing. And one day, Dr. Brackney and I are going to figure it out. We're going to retire. We're going to get Nobel Prizes. We're going to be really rich. We're not going to work anymore. But now we don't know why, because we sing the whole pregnancy that the cure of preeclampsia is delivering the baby. And there's no baby around, but it presents just like it. So we manage it just like we do in pregnancy, except we don't have a baby to deliver. And most times, once you stabilize, things get better. But this can happen traditionally up to 12 weeks postpartum. Right? So again, she's out of the triage presentation area, but she still may be having preeclampsia symptoms and signs, and we don't want to miss it. So having a checklist like this around wherever is convenient may be helpful for those patients, especially if they're presenting with blood pressure issues. This is an algorithm or just a really quick way to initiate and work on magnesium, because that's our only thing we have for preventing and treating seizures or recurring seizures related to pregnancy. Very different than seizures outside of pregnancy related to seizure disorder or fever or drug use. This is our go-to. This is the mainstay, and we want to get this started. And I know my colleagues in the emergency department love to give like benzodiazepines and things. Now, that may work, but you got to get them on magnesium to prevent at least the recurrence of it. And it's giving as a continuous infusion, and it's all here. And then if she seizes on magnesium, you give her a little bit more. So we've really exhausted, but that's the best thing we have. Magnesium is not an antihypertensive. So you have to be as well treating her blood pressures as you're giving this medication. It's twofold to prevent any really big complications related to preeclampsia. So when we talk about referrals, then you have the patient who has a positive cardiac screen, but she's not being admitted to the hospital. What do we do with her? If she's not currently pregnant, but she's been pregnant in the past year, we want to make sure we get her to her primary care doctor or set up or establish care with the primary care so she can be monitored. If she's pregnant, send her to us. You like patients, MFM. We'll take care of her. And dually, hopefully you can get her in with a cardiologist, but usually that's part of our work as MFM is to get that referral happening and she can get appointments. Now, where this comes in, you may come up with a flow system to make sure that appointment is actually happening before she walks out of your unit. If she's a patient with a positive cardiac screen and being admitted, if she's pregnant, call the OB MFM service right away so they can get involved in care. We have these as well. These are little business card size cards you can give a patient as she's leaving your unit to say, hey, we noticed something, hand this to your provider so that even if you can't remember what I'm telling you, the card's going to tell the story for you, that we recognize something's going on. And with that, these things are suggested to happen. Referral to higher level of care, more workup for evaluation, and maybe even treatment. So key points, and we're at the end here, I promise. If you have a first presentation of cardiovascular disease, that can happen actually in pregnancy or the early postpartum period. So definitely believe what you see if it's occurring. Highest risk is between 24 and 28 weeks. And then again, postpartum. Actually, when you get into that frame, the 6 to 7 month frame, the heart starts to work harder naturally. Usually peaks between 7 and 8 months. So a lot of times with someone with pre-existing conditions, we'll reevaluate their cardiac status in the 3rd trimester to make sure it's holding strong. Any symptoms, vital sign that triggers you, please don't ignore them, work them up. Any new onset asthma is a big deal, right? Because that could be a deterrent. It's really not her lungs, but her heart is telling you something's wrong. You should definitely work that up for heart failure, even if it's just doing a strategic history taking moment. If you see infiltrates on the x-ray, that can be due to heart failure as well, right? The backup of fluid, it may not be related to pneumonia, especially if she's not having any of the other signs and symptoms of pneumonia. Pregnancy or postpartum women with significant risk factors should be counseled about their CVD risk. What we were learning about and what we've learned about recently with preeclampsia very quickly is that it remodels the left side of the heart. No matter how bad it was, that left side of the heart has remodeled to accommodate the change, and that could be a permanent one. So what we're seeing with the data coming out so far is that this could lead to long-term cardiac issues. So she's 22 now with bad preeclampsia. That could mean in her 40s she has a fatal heart attack and dies, or maybe 30s, or maybe her next pregnancy. So having that discussion with the patient about the importance of disclosing the history, because sometimes they think pregnancy is a totally different type of history no one else needs to know about, and then making sure to follow up with the appropriate providers to keep monitoring lifelong. They should receive pre and interconception counseling, hopefully by a perinatologist like myself, Dr. Brackney, or a cardiologist, to talk about what this all means for health, and is contraception the best thing for you, or is permanent, or just timing of pregnancy and spacing of pregnancies. All those things matter. I feel like sometimes we get shy about contraception discussion because they're pregnant already, but it should be part of that discussion. And I think it needs to be revisited. You know, when she's in the ICU on the trip with one eye open, probably not the time to tell her about birth control. Circle back at the 6-week visit. Circle back to the right, discharge. Which one? Just point to the one you're gonna be. And I think sometimes we forget the stress of the event can help people to forget all the other important things you're telling them, right? And then educating ourselves and reminding ourselves is probably a great. You know, we do the active shooter training every year and the cyber attack. Should probably put this in that list of modules yearly to remind everyone. All these things are going to matter, right? Notice it early, evaluate it early, treat it early are key elements to preventing mortality and morbidity. All right, I think this might be. Want me to stop, Brenda? I can stop. I think it was just kind of a review of what to do with our non-OB providers as far as when it comes to if you recognize something or you have a pregnant patient, right? Hey, bottom line is you can call the OB. The OBs know how to find us, I promise, every time. And they'll be able to guide you through. But this just goes through kind of the things you're going to be looking for, as far as triggering. And we've covered a lot of them with just exercise intolerance, wheezing, coughing, shortness of breath. Weight gain is really important, unusual. Of course, every pregnant woman is going to pick up weight. We say on average up to 35 pounds. But if she's gained 5 pounds in 5 days, it's not. I mean, I guess if she's eating cookies all the time, maybe. But if they're picking up a significant amount of weight on a weekly basis, that should trigger you because that's water weight, which is third spacing, which is not normal, right? Even though they're carrying a baby that's growing.
Yeah, no baby grows 5 pounds in a week.
No, not if they want. They try to blame sometimes as babies, but it's not. And then wanted to make sure we identify the symptoms that all of our emergency departments and other touch points like urgent cares, even ICUs, have those systems in place to evaluate, potentially start the workup that needs to happen outpatient, and then really important to connect to continuing care. And because a lot of these things will turn into, again, long-term issues for the patients. We talk about crackles, we talk about how not to let lung findings deter you from working up for congestive heart failure or other problems with the heart as well. And again, circling back to why we're here today, and that's the project that involves everyone collaborating to make sure we're doing appropriate screening, early detection, and evaluation to lower the morbidity and specifically the mortality around this condition in pregnancy. Guess what, guys? We have a podcast. Listen, we love to get the word out in any way you want to get it. But I encourage everyone to go to your favorite podcast entity and download Healthy Mom, Healthy Baby Tennessee. You can actually get it through our website as well. But we do 30-minute podcast talks on a lot of variety of topics related to maternal health and infant health, specifically cardiac conditions. We have about 4 podcasts talking to national experts in different areas regarding cardiac conditions and pregnancy. Quick listen to while you're coming to work, going to work, or
You'll hear, it's mostly women from Tennessee or doctors or patients from Tennessee,
absolutely.
which is kind of cool. You'll sometimes hear people you know, or
I believe this patient, she delivered at Regional 1, I believe. Whitney Brown. So she tells her story. Dr. Graves, we mentioned this MFM in Nashville. And then we have other partners from other states. Dr. Florio actually is Vanderbilt cardiologist, right? No, she's in a different state. Yes, we do have one coming out from the cardiologists in our area, so meaning the state. And I like this too, because you learn about your local resources and not just assume that someone would have to go very far distance to get the help they need. We have a lot of great resources here in the state of Tennessee, and TIPQC is helping to take advantage of one, putting the spotlight on them so you know, and then getting everyone connected to them as a resource. We have many partners. They're all listed here. We appreciate all of them because they allow us to be able to bring this information to you and to keep the work going. And of course, we love to partner with anyone who is on the same mission, and we love our hospital partners especially because you guys as teams are doing the work, and we know that you will continue to do it fabulously, as Bonnie Miller says, and know that we are going to continue to move that needle and see those numbers drop because we definitely don't want to stay at number 47, right? We'd love to not even be on the list if possible, but I know it can be done and done in our work lifetime. Any questions? I'm officially finished. Any other questions?
So chronic hypertension postpartum patient with severe range blood pressures, like more than 160, obviously. So, but they're always on that level, right? Because some patients are super non-compliant. So they're always saying 160s, 170s usually.
So usually, and the question is about chronic hypertension with severe range pressure postpartum. And I think first things first, you have to rule out preeclampsia, right? Don't just assume, even if you have proof that she was not the most compliant or adherent or well-controlled patient before. And then second, it may be time to revisit what she's taking, because most time right out of pregnancy, we still have them on the pregnancy meds. And is it time now she's not breastfeeding and she can go back to her usual regimen, which is usually much more powerful, right? Most people are on an ACE inhibitor plus a diuretic, and we can't give either one of those. And then, of course, making sure, and this is where the in-between comes in my opinion. This is a patient you can easily observe in the hospital overnight. We don't have to rush her home to maybe not do what she needs to do, or even have her on a regimen that really doesn't work, because that could be an issue. but we don't have to keep her long-term in the hospital, right? But what I see a lot of times people will do is just store a little bit of medicine and send them out the door. And it's like, that might not be the end of her story. You haven't even gotten a 24-hour idea of what her need is. So maybe we need a better check-in system, right? And definitely tap into research.